We will share with you some experience, what is going on in these topics that we have already heard about this morning, about nutrition on one side, but also bulbar function on the other side, and how we can improve the global management of the patient care and to increase the benefit and the well-being of patients. And we will have a number of speakers, of experts, and people sharing their experiences in terms of best practice that we can say from different countries around the world, but also some ongoing projects, because as you have seen, there are a number of unanswered questions that still need to be addressed. And I will start by giving to you, which is our experience. I work at the Great Ormond Street Hospital in London, and it was very formative and important for me, the ongoing collaboration with the team in Milan that we have heard about this morning, Simona Bertoli and Ramona De Amici, that have discussed and provided to you their very long-standing experience in how to build up a very disease-specific management for this condition. And it was said already that there are no clear guidelines, but we are trying to implement, based again on this experience that we have accumulated and based on the ongoing experience that is becoming available across the world. We have tried to build up a sort of strategies to best monitor our SMA patients. We know that there are specific guidelines, the standard of care recommendations published in 2018, and were also discussed and presented to you today. But these guidelines are also evolving, and it's not always easy to implement at the local level, the basic requirements to monitor these children. So what we try to do is essentially to have a very dedicated referral to dietitian in our hospital immediately after diagnosis, and we know that this is particularly relevant for type 1 baby. So we really try to refer the patients as soon as they are diagnosed to the dietitians. And this is I would say, the cohort of children that we try to monitor more carefully and more regularly, at least every 6 months when they come to clinic. In other cases, we try to have a very individualized approach also for other children with type 2 or type 3 patients. But this is mainly based on specific ad hoc observation or indications. And we rely heavily, at least in the UK, but I think that this may apply also to other countries, to the local community services, because it's very important to engage them in the nutritional management of these children. And again, it's very important. We have heard how the nutritional assessment of these children should happen with a very detailed anthropometry assessment. We collect information regarding the dietary intake. It's very important. This is very basic for all the nutritional services, and they are very familiar with this. There are different methods. There are diaries that can be filled in by parents or even patients. We used to collect the 7-day or the 3-day typically diary because these give you information about the dietary intake of the patients. But it's also important to discuss clearly with them, because sometimes families or patients, they can just indicate, I hate pizza, but how much? How many slices or what other ingredients there were. It's very important, from the dietetic perspective. It's also very important, as we heard this morning, about how we calculate the energy requirements. Of course, we know that individuals with SMA, especially at the most severe end of the spectrum have a very limited amount of physical activity, and this is why the majority of their energy is used for the basal metabolic needs, for breathing, for the cardiovascular system, and so on. And to do this, there are predictive formulas, but now we have, thanks to the work that has been done by the Italian team, we have dedicated specific formula to predict the energy requirements based on, especially for type 1 babies, but there is ongoing work also for the more chronic type 2 and type 3 patients. And there is a formula that is able to predict their energy requirements, but if there is the possibility, we have the calorimetry machine, and this gives you a very individualized energy requirement for each individual cases. Protein intake is also very important. We found that it's very common that patients tend to overfeed, especially in terms of protein intake, and this needs to be for sure based on the recommended dose, but also needs to be customized based on the lean mass of the patient, so the muscle amount of the patients, because these patients may need lower amount of protein intake. We also try to somehow implement the very well detailed and standardized protocol assessment that we developed in Italy, and we used to monitor regularly body composition with the DEXA, and also the bioimpedance, bioelectrical impedance. We monitor the presence of gastrointestinal symptoms. We have heard how common this may be from patients, and sometimes it's very important to capture them properly, and there are validated questionnaires to do that. We also try to administer the calorimetry to every patient, especially when there is a problem of overweight, because this gives you a very precise and individualized requirement for the calories that are needed for that specific patients. And we also collect information regarding family food habit, because of course this may have an influence. You know, we live in a very multicultural, multi-ethnic environment, and it's very important to see how the family habit may impact nutritional management in these patients. Another aspect that we were particularly intrigued on was the application of amino acid diet. There was already this morning some discussion about the use of the amino acid diet. We know that there is a very strong, again, because there are very common unmet needs on how to best manage nutrition in these patients. Sometimes it's very common that patients or families try to do that by themselves because they don't find enough support, in the clinical setting or by the expert. And this is why we decided, given that there was a very strong feeling about this approach, we started a discussion with families and advocacy groups. Okay, let's try. We want to listen from you, which are the benefits that you perceive in terms of this approach. And as you see here, many families were reporting improvement in airway secretions, improvement in the respiratory management, in drooling, in constipation, in reflux. And some of them also found some improvement in terms of strength and fatigue and the quality of sleep. So all these aspects, of course, may impact heavily on the quality of life of these families and these patients. What is the amino acid diet? These are, you see here, the three main components that are somehow the scaffold of this approach. So it's based on branch-chain amino acid, isoleucine, leucine, and valine. There is a very high content of carbohydrates, a very low fat content. And we sat together and we designed a protocol. Of course, we needed to provide or start to build up some evidence about this, and we wanted to have a more scientific approach. We also wanted, with the support of our dietitians, to give something that was not dangerous or outside or could trigger some safety concern for these patients. So we ran a pilot that was a single center study only at Great Ormond Street Hospital in type 1 children, using a formula that is enriched of amino acid that is commercially available, and we started a collaboration with one of these pharma companies that provide these products to test that in clinic. And this is a formula that has essentially the 34% of triglycerides, so these are medium chain triglycerides, 50% of carbohydrates, although in what is called the amino acid diet protocol that is commonly used in the US, for example, but also in the UK, the content of carbohydrates may be even higher than 50%, but to go higher was not considered safe, so by our dietitian. So we started with this approach. And also there is a very good content of probiotic and prebiotic that are commonly added to the amino acid diet protocol that is in use among families. We recruited a total of 14 children with type 1, and the mean age, as you see here, was 4.1 years at the recruitment. And this was a crossover study for 8 weeks. So the patients started with either this formula or the full protein formula, and then they crossed over for further 8 weeks. The main primary endpoint that we wanted to look at was the effect on the gastrointestinal symptoms. We have heard that these are very important and crucial in the management of nutrition in SMA patients. And as you see here, it was very, very clear immediately after starting this protocol that there was a complete switch from the presence of disorders like constipation, or even being relying heavily on medication for constipation, or the presence of reflux or loose stool. You can see here then on the right side that essentially the vast majority of these disorders basically were sorted after the implementation of this typical approach. And indeed, the majority of the families didn't want to go back to the whole protein diet. So again, this is just to share an initiative that we have developed. It was only a pilot study to gather initial evidence in terms of the benefits. But we know, that actually by listening at what the patients were reporting and try to design a more scientific approach led us to understand that essentially something can be done to improve the nutritional management in this patient. And of course, this would trigger additional studies to go more in depth. We are also studying the bulbar function, as it was mentioned, with the PFOIs, so something that will require additional investigation and larger studies. But definitely something is moving, and this is really to share with you that we are very well aware of the difficulties in all these fields, how it's very important now that we have disease-modifying treatment, how we can boost the effect of this medication, and definitely further collaborative approaches are needed, to demonstrate the effects of these approaches. So thank you for your attention, And I think that we will hand over now to Kathleen. Kathleen, it's up to you.
Perfect. Thank you. Awesome. That is really exciting research and data coming out. So I'm just going to follow up a little bit with some points from my talk that I did the previous session and piggyback on that for some advances in nutritional care that we're doing in the United States. So this is just a schematic, I would say, my perception of how things typically run in many SMA clinics that I've seen in the United States as well as internationally. And that's where we're starting to get really good at having these multidisciplinary teams that look at many components of patients' respiration, neurologic function, motor control, nutrition, systemic health. And that's done in an interdisciplinary, multidisciplinary way. Which we know is clearly optimal for best patient care. And then, if a patient has a deficit that is detected at some point in these clinic visits in bulbar integrity, then we have these consult services typically that go out to somebody, say in speech pathology, that will evaluate the patient from that perspective and ideally communicate that back to the team. But this practice is really problematic for a number of reasons in SMA specifically. So, as you can see here, one of the reasons is just that swallowing problems are pervasive across patients with SMA. I should say bulbar because whether it's swallowing or speech communication. So here is just some data looking at the incidence of dysphagia, where historically untreated patients, pretty much all patients had dysphagia in some capacity. If they were type 2, we have 62% of patients with dysphagia, and type 3, 23%. So clearly, like this incidence of dysphagia warrants more than a consultation service approach and more of the systematic approach like we take with physical therapy, for example. So to summarize, really the U.S. initiative, I feel like it's a big burden to speak on top of all places in the U.S. But I think, generally speaking, a theme throughout the United States is that we're trying to bring the bulbar assessment into SMA clinic. Now, whether that is equipping the other healthcare professionals, such as neurologists, physical therapists, allied health with some assessments that they can do to facilitate a standard routine assessment in clinic, or ideally bringing the speech pathologist as part of the interdisciplinary team. Both aspects of that are certainly ideal. So, how are we doing this? Well, there's really two primary ways that we've been working to do this. The first is by facilitating speech pathologist training. So, as was mentioned before, there are very few speech pathologists available that do medical type speech pathology to begin with, even fewer that have expertise in swallowing, and certainly even fewer that have expertise in spinal muscular atrophy. So, one of the key things that we're doing to help kind of change the way that this picture looks in identifying these deficits so patients can get the treatment that they deserve is that we're helping to train the clinicians to do this. And I should say that the lack of clinicians in most SMA clinics isn't result of their not desire to be there, because what I find overwhelmingly is when I'm talking to the clinicians, they get really excited about working with this population. Why wouldn't they? These are awesome patients that we have. And so what we've done is we have the consortium specific to bulbar coming out of our lab, where we hold webinars that give, overviews of SMA. We have some videos available for them to learn if they're looking to get involved. We've actually been reaching out to different sites. If there's, a neurologist at a certain site that says, I really would love a speech pathologist on our team to help get involved. If we have a contact there, where we have a fair amount of contacts different places now, we can reach out and provide them some of these resources. And then as this, landscape is changing so quickly, we hold these webinars typically about once a quarter, where we provide the most up-to-date research that we have from a bulbar standpoint in what are the deficits we're seeing, what's the best patient management, so that everybody's calibrated and on the same page. So that's one main vein of this. But then the other one, of course, is because this is a changing landscape, is getting more evidence. And so, really making sure that what we're doing is doing research that's clinically relevant and then making sure we're disseminating that. So, what I want to talk about in the next few minutes is the evidence based assessments that we now think we have sufficient data to recommend as this is how we should, in an ideal setting, progress with bulbar assessments. And again, this is when available. We understand that throughout the world, there are different constraints based on assessments. So for the sake of time, I'll just focus on what we're recommending from a video fluoroscopic perspective. But please know that this also includes us looking at the patient clinically during all of their SMA visits. But from a swallow study standpoint, as was mentioned in one of the first sessions, previous recommendations were for patients to get swallow studies if they had type 1 and then follow up as needed. And if it was less severe forms, then the clinical exam was sufficient with follow-up as needed from that. But we know that rates of silent aspiration are high. And now in many places, we have newborn screenings that are detecting SMA before we even know the type. So what you can see on this is patients with natural untreated swallowing deficits. And on the x-axis is patient age, the y-axis is function. The scores to the top are the best and the lowest are at the bottom. And this is showing in patients without any disease modifying therapy how we have this degradation in swallowing over time. And this is based on some work, pilot work that we started trying to identify what is the natural degradation of swallowing if you don't have treatment. Well, what we've done with this pilot data is come to guidelines for when we should be doing video fluoroscopic swallow studies to do that more instrumental approach to supplement those clinical assessments. And that indicates that we should do a baseline video fluoroscopic exam as soon as the patient first comes into your clinic. So for us, we have newborn screens. That typically means we're seeing the patient when they're about a week old. But this applies even if you're not doing newborn screens. So the first time they have their first diagnosis of SMA, whether or not we know the type, this is to get their baseline function. And like I mentioned, this is critical in knowing what are their functional impairments, physiologic impairments, and seeing how those two relate. The reason we then do a follow-up in 2 to 3 months, regardless of what we see in that baseline exam, is because of the data that we gleaned from that pilot study showing that we have patients that can have complete loss of swallowing, PES opening, that esophageal segment opening by 3 months of age. So this can occur very, very early on, indicating that time span can be enough to make a change. So we typically will partner these with their clinical visits. So I say 2 to 3 months. We certainly don't want patients that are traveling from far distances away to make a separate trip just for a swallow study if we compare it with another clinical visit. And we'll do these for every 2 to 3 months. It's an abbreviated exam, so limiting radiation exposure, but providing us a glimpse into what's going on internally. So we're not relying on patient reported outcomes for that because we know from the research in natural history patients that those patient reported outcomes, especially for the infants, are not a good predictor of what their swallow study exams are indicating, and often would say parents would indicate my child is feeding fine, and then within a week that child was admitted into the hospital on respiratory support and they're found to have profound swallowing deficits. And we do this up until about 9 to 12 months of life, because the data from the pilot study indicated that we can have degradation up until that point. Now, again, this is coming from a pilot study. We have the full study underway, which is very exciting. And so this guideline may change based on that evidence, but this is kind of where we stand at this point. So we do, just as a recap, these routine clinical assessments in clinic, whether that's virtual or in person, and then we partner that with the instrumental assessment that we repeat every 2 to 3 months. And this has really been key, as I mentioned, in patient cases where we see some slight deficits, such as, maybe that patient has laryngeal penetration or maybe even trace aspiration early on, but they're not having any functional signs of that. They get early disease modifying treatment. We halt the progression of that loss, and we can monitor to see, do we need to be more conservative in how we manage things or not? And I've had patients go both routes, but seeing them this closely has made it so I'm comfortable playing more of a liberal route and say, let's just wait and see how this goes. Of course, in conjunction with my colleagues in neurology and pulmonology. And with that, I'll hand it over, but I seem to have lost control. So I will let IT take over. There we go.
Okay, thank you so much, Caitlin, for that presentation. It's exciting to see the new developments in research for some of the bulbar assessments. My name is Tina Duong, and I'm a physical therapist. So I'm going to take a little different approach towards looking at nutrition. And so beyond nutrition, we, just like everything else, is multidisciplinary. So I'm going to take kind of the motor, get an understanding kind of the motor side, as well as how physical activity and exercise may impact some of the nutritional recommendations. And so first I'll start with trunk stabilization, posture, and breathing. We talk about nutrition, but sometimes posture and breathing really impacts our ability to eat or attain the food. And that also contributes to some of the fatigue factors that was previously discussed in the last session. So in regards to postural control, we're really looking at different systems working together, and that includes the musculoskeletal, neuromuscular, and cardiopulmonary system. And I'll introduce you to this theory that a lot of physical therapists work off of by Mary Massery, in which we look at the trunk as a force of stabilization. And so we look at the framework of the spine and the rib, as well as the intercostal muscles creating the frame, and the musculature of the diaphragm, abdominals, and back extensors together to really create that pressure. And that pressure really allows effective respiration, eating, and swallowing, and as well as upper limb and lower limb function. And so with that, I'll kind of take now look into exercise and what we know about exercise in SMA, because when we increase exercise or maybe change some of our treatments, we may have to modify the nutrition that we need to meet those physical activity needs. So when we're looking at exercise, we know it's necessary for both healthy muscle function as well as individuals with SMA. And in the standards of care, it is suggested to exercise to improve function, strength, range of motion, endurance, and balance, as well as the usual benefits of exercise for physical well-being. Most of the guidelines in general for SMA include strengthening and cardiovascular on a moderate intensity level. What that generally means is for your relative intensity, you should be able to talk through an exercise, but not necessarily sing. So you could see how not precise we are in an exercise prescription, making it possibly difficult to measure the amount of activity that someone is doing. And that was well published on some of the Cochrane review by Bart, which he looked at the evidence available in SMA. And you can see most of the evidence is in a C or D level, meaning they're not randomized controlled trials. Most of them are single or observational studies, which is helpful, but it's difficult to extrapolate information and translate that when there's lack of RCTs. However, what we do know from these studies is that resistance training is safe and is feasible and tolerable in individuals with SMA. Also, it does have exercise capacity impacts with improvement in oxidative capacity for individuals with SMA. But then when we look at exercise and nutrition, there's really no studies out there that look at both. And so we know that sarcopenia is evident for individuals with SMA. So I reviewed the literature and looked at a meta-analysis. It looked at sarcopenia in individuals who are of older age. And in this meta-analysis, they looked at and compared the effects of exercise, nutrition, and the combination of exercise and nutrition. So they had those three groups. And when they compared exercise and nutrition alone, they found that exercise did improve gait speed, muscle strength, and physical performance for older individuals. When they looked at these three groups in regards to looking at muscle mass, they found there weren't any differences. However, when they did a sensitivity analysis, they found the combination treatment of nutrition and exercise were most sensitive to change. And some of the discrepancy in the ability to detect if nutrition was made a difference was the variability in the studies and what kind of nutrition was monitored in those trials. We know that nutrition can contribute to obesity. And we know that obesity in general impacts physical function. And for those who are weaker, that even has greater impact. As Sarah mentioned in the first session, that she went from being overweight to underweight, and how is it that we can better manage this so that we can advise patients on how to have an exercise prescription that may impact, or recommendations on nutrition that may impact that. So some of the current recommendations, I won't go through this, but this was prior to disease modifying treatment. Really estimated protein suggestions were 1 to 2 grams per kilogram of body weight. And this is required for patients to maintain muscle mass. And so then I will present to you this case of this very unique individual. He's a type 3 person with SMA. He's 24 years of age, and he started disease modifying treatment around March of 2020. But the unique thing about him and why I'm presenting this is that he started exercise and nutrition before his treatment. And in doing so, he also had a DEXA scan done, in which his dietitian used this to provide recommendations for his nutritional recommendations. In the DEXA scan, you could see on the right that there was no difference in left or right side for his lean body mass. However, when you look at his strength on the left side, for the weaker muscle groups, which are the extensors, they're about symmetrical. But for the stronger groups, which are the knee flexors and extensors, you did see that strength difference that wasn't really seen in the lean mass on the DEXA scan. In his nutritional intervention, originally he was trying to lose weight, thinking that will improve his function, not having so much weight to carry around. So he decreased his caloric intake by his own recommendation to 900 kilocalories, which was too low. And so his dietitian was concerned about possible loss of muscle mass. And so she revised his caloric intake to 1,450 kilocalories per day, and having a combination of protein, carbohydrates, and 54% fat. What I'd like to kind of point out here is that in his treatment, he did have he monitored physical activity through a fitness app, but the nutrition plan I thought was really interesting, because that's a nice way for us, if we were choosing to do and needing to do research in nutrition for SMA, we could have a nutrition plan such as what this young man used, trifecta, and that it allowed him to monitor his exact protein intake, etc. With all this, DEXA showed increase in lean body mass with his exercise, and he showed improved function overall. And you could see here, this was seen also in his Hammersmith motor scale, which before he started treatment, he had a total score of 34. And during this time, this is the exercise and nutrition program that he went through 5 months before treatment. And then he started treatment, and at treatment, before treatment, he had a total score of 48, which, take this with a grain of salt. It is a case study, but you could see how a combination of nutrition and exercise could, one, increase his confidence in some of the physical activities or motor assessment or motor functions that were required for the Hammersmith, but also it does correlate well with what we're seeing with his lean body mass and his reports and function. And you could see here after he had treatment, there was COVID, and he did maintain, even though he had decreased exercise program after because of COVID. And so one of the other gaps that I find that's difficult in advising patients in their nutrition when I work together with a dietitian is the ability to monitor physical activity. If we, in order to monitor physical activity, we need to be able to have a general idea of what the metabolic cost is. And how do we do that for patients who have more limited mobility? And so we know, as addressed by the first session, that there's indirect calorimetry is the best and ideal way to measure basal metabolic equivalents. However, that's really difficult. And so a lot of times people use physical activity questionnaires. However, even though that's feasible, it's not very valid. And so one of the things that was suggested was physical activity monitors. It is nice to use, but these off-the-shelf physical activity monitors are able to quantify physical activity. However, it may not relate so well to someone who is non-ambulatory or even those who are weaker walkers in SMA. So what do we do then? So one of the gaps that really need to be measured is really our ability to assess physical function, or VO2, in individuals with SMA, so that we really can develop a way to measure metabolic costs so that we can inform better nutritional recommendations for our patients with limited mobility. Okay. And with that, I think I will pass the baton to Dr. Sansone.
Thank you, Tina. And I'd like to present now some additional exploratory measures in the nutritional care. And the first question is, why do we need actually exploratory measures? Well, we've heard so far from the whole morning and even from Tina that there are still gaps. There are some things we are quite certain of. And the first one is that swallowing problems are actually prevalent in SMA. And one other thing that we all know as clinicians is that the subjective perception is a bit different, as we've heard, from what the objective measures show. So there may be more there than we think. And unfortunately, dysphagia is still one of the major causes of death in neuromuscular diseases. So I think this is a really crucial workshop and things that we really need to work on. And as we've heard, there is lots of work going on, but there are still no definitive outcomes and consensus as to what should be done and exactly how to measure it and precisely in what features of the swallowing issues. And in fact, we all know that when we talk about nutrition and swallowing, it's not just the motor neurons. We know there's the muscles involved. We know there's the postures involved. So there are many more things than just looking at how a patient is able to swallow. And we are also watching the new drugs that are there already, and they are doing some differences. They are bringing some changes, but we need to measure and have some numbers to provide data and be confident, first of all, us as physicians, and then patients and caregivers, and finally the regulators. We can't just rely on what our perceptions are. So let us start by giving a brief overview of the International SMA Consortium experience, which involves several sites, and these sites are collecting data worldwide, and they are looking at the several things, and this slide especially concentrates on the swallowing issues. And if we look at what we had collected in 2017 for the SMA1 patients and how that has changed in 2022, mind, it may not be the same patients, but the overall percentages do reflect how things are. So overall, more than half of the children with SMA1 in 2017 were with a PEG tube, and roughly the same percentage is maintained in 2022. This is not because of the inefficacy of the drugs, but because the patients with a PEG tube still keep that PEG tube. And the criteria to maybe revise that and go over and see if that was the case actually and if changes can be made are still to be defined, and caution is always there to guide us when we look with our patients. And as you can see, in 2022, none of the patients had a nasogastric tube in the percentage that we were looking at. And the interesting thing is that 44 of the children, these are patient caregivers reports, of course, reported that there was no problems with oral feeding. And of course, that was the result of having the PEG tube. So the data needs to be looked at with caution, but it's still interesting to see how and the ways in which we look at the data that we are collecting. And if we look at the types 2 and 3 SMAs, and we do the same type of work and analysis, we do think that, again, the percentages of patients reporting a problem is compatible to what we know of the milder forms of SMA, but still it's prevalent, and some still need to modify their diets. But when you ask, if there's a problem, if you have already overcome that, the tendency is to think the problem is not there any longer. And when you go and test it, you may find some different things. So these are the exploratory measures that we're actually working on. We are regularly looking at the mouth opening in these patients. This is nothing new, nothing exploratory, but again, the way you do it and collect it and be constant with your measurements is something important. We're also looking at the time a person takes to swallow a defined cracker, because as we have heard also from Professor Mercuri, when he was discussing about the role of dysphagia and what we think of dysphagia, it's not just the pharyngeal part, it's also the oral phase of it. And so the way you bite the cracker, the number of bites you take, the time the number of swallows you take, the cycles of moving your tongue within the mouth and then pushing the bolus down into the pharynx. So there's a number of things that can be looked at, and we can provide actual numbers and split the problems in parts to better understand where we could actually focus more. And we're also looking at the strength of the lip muscles, which is also important to provide a good feel of what you're biting and eating. And we're looking at the tongue strength to see how that can influence and be impacted by treatment, and to see how that works at baseline. We're also looking at what happens to the actual neurophysiology of the muscles involved in the face, because we have looked and found from experience with the patients followed at our site that unexpectedly with any of the treatments, some of the muscles started recovering with some movements, some flicker of movements, which were unexpected. So we are now looking at the way a lip, maybe the upper limb changes a movement, or there's a better movement of the tongue, and we're trying to record from with the surface EMG to look at what's happening. And because it's a surface EMG, there's no needles, it's well tolerated, and it is providing interesting data showing the neurophysiology of what's going on, which again is a way to try to find numbers to understand what we're doing. And so just to give a brief summary, we these are just preliminary data, just a pilot results. We have been looking at roughly 49 kids, and you see the ages there, and 35 adults, and we've been through all the tests that I showed. And basically what we have found is that if we look at the green part of the table there, the pediatric population, 60% of the children actually show a reduction in their tongue strength, and 40% actually have a reduction in their mouth opening. And many of the kids, and this is a range around, a mean is around 6 years old, they are not really aware of that. And 45% of them took more time than the comparable age group of without SMA actually take to masticate and swallow the cracker. And if we look at the nutritional asset of these patients, 70% only, or actually maybe not only, had normal BMIs, and only 2 children had a PEG tube. So Again, this depends on how you read these data here, but it may also suggest that when we think of nutrition and swallowing, it's not just the BMI which is going to guide us to see if there's problems. There may be problems with biting, with moving the tongue, which may not necessarily impact the BMI because we're overcoming that with other things and dietary supplements, etc. But it can be something that can be worked on, the opening of the mouth and the tongue movements. And same thing for the adult population. You can see the numbers there. But again, we think of adults, we think that the problem, as we've heard from the outcomes reported, the patient-reported outcomes is quite a low percentage. But in fact, 50% of the individuals did show that their tongue strength was reduced. 44% could not open their mouth properly, and 24% took more time to eat a cracker. Again, this has implications depending on how you read this data, but it does show that, in fact, the mastication and swallowing are issues in SMA. Of course, it's more so and more severe and more critical as an outcome in the type 1 SMA, but it does not have to be underestimated in type 2 and type 3. Unfortunately, it just needs one piece of bolus that does not go the right direction, which causes a problem. So we must be aware of that, and we can think that we can work on these things, and that it's not just the pharyngeal part, it's also the tongue strength, the mouth opening, and the jaw opening, which play a role. And so these are things that can be worked on. And probably as to now, because we do not really have a straight consensus, probably a multimodal approach, so be more inclusive and looking at more things is a better and more cautious way to proceed, because we do not have the exact answer to what should be looked at in a single way. So I think that for now it's best to be cautious and start thinking that we really need to go into depth here. And this is just to show that we need to work in a multidisciplinary and integrated approach. It's not just the neurologists, of course, or the child neurologists. It's a whole team, including the nutritionists, the pediatricians, the physios, and the network. And I think that what we've heard so far, and what I think Tim is also, and I'm passing on to him, is also going to show us is the important thing of being in a network. And with this, I thank you.
Thank you, Valeria, and thank you for the inspiring talk and ideas you presented us on swallowing function. Well, from the German side, unfortunately, there isn't so much I have to report. Especially in Germany, we have the situation that it is unfortunately of most utmost importance to emphasize more on the need or on the problems patients suffering regarding nutrition, as well as masticatory and jaw closing function and so on. So as a first step to do so, we have established for the first time in Germany a management guideline for the treatment of SMA, including infants, children, as well as adults, and it has been published in 21. It was the first interdisciplinary guideline, including pediatric colleagues, genetic colleagues, orthopedic surgeons, for example, as well as adult neurologists and so on. And as a small part of that first idea of a German management guideline, we defined that it is necessary that a phenotypic specific disease management needs to be established, especially when it comes to nutrition. So we defined the typical problems that you may be aware of. So in that guideline, we already focused more on the current motor situation than the classical phenotype. So we defined non-sitters, sitters, and walkers. And for the part of nutrition, we highlighted the risk of aspiration, dysphagia, and increased muscle exhaustion of the bulbary muscles, the risk of further impairment due to contracture of jaw closing muscles, and we suggested that swallowing should be examined, for example, using a flexible endoscopy, and that for giving enough energy, that a percutaneous endoscopic gastrostomy may be established when it is necessary. Well, when we look at the sitters, we also underline the development and difficulty of chewing and swallowing, and especially in that subgroup, we started to give more focus on the risk of obesity, because as already highlighted by Tina, obesity is also a factor that further impacts mobility, and the same for walking patients. Even if they typically don't have to deal with chewing problems, they also have to deal with the risk of obesity. And when we look more closely on chewing function, we already do some exploratory studies, especially in a close collaboration between our center and colleagues from maxillofacial surgery from the University of Cologne. Beside tongue pressure, we also measured bite force using a device that come from the dental surgeons, and we followed the patients even under different treatment situation. And I think in the next year or at the next conference, I can also present you some data on that, because we see that treatment modification also possibly impacts this function as well. It underlines the need for further looking on chewing function beside extremity and other motor domains. So this is what I have reported so far, a little bit short, but you see that there are still some countries, even if we have established several expert centers, there are some domains in which we have to focus more, for example, the bulbar function, especially as for the nutritional side. Thank you.
Thank you very much for inviting me to this conference, and for having the opportunity to share some of the best practice in the Netherlands. Of course, we have a multidisciplinary team for the topic of feeding and swallowing, in which the speech and language therapist is central. And what I would like to do today is share some of the most important issues that we have encountered with you today. And I would like to focus on two main topics: jaw mobility and the jaw contracture, which is very common in SMA, the problems it gives patients while chewing, so during mastication. And I will just make a short remark regarding the issue of swallowing that has been covered by many others today. So the first thing that a neurologist runs into is that you really realize you're not well trained to measure bulbar function or to assess bulbar function in any way. We really need speech and language therapists to do that for us. And there is maybe one exception, and that is measuring mouth opening with what I call the ruler test. And why the ruler test? Well, of course, that is really simple, because if you measure mouth opening, it can be done with a ruler. And of course, there are all kinds of other tools as well, disposables you can use for this specific purpose. It's a very easy test. And I would like to point out here that measuring mouth opening is relevant, because it will probably give you an idea about mastication and maybe even about the swallowing efficiency. So just to start here, if we look at mouth opening, some 20 years ago, it was already published by Granger and colleagues that mouth opening might be an issue, or at least the lack of sufficient mouth opening. And what we did 8 years ago is look at maximal mouth opening in 145 patients with SMA types 1 to 4, so type 1C to 4, with an average age of 25 years. And what is shown in the figure here is maximal mouth opening. The dotted line of 35 millimeters represents the lower limit of normal. So most healthy people have a maximal mouth opening of 35 millimeters or more. And you will appreciate that in patients with type 1C and type 2, this is often not the case. They have mouth openings less than 35 millimeters, sometimes even less than 20 millimeters. And for type 1, it's virtually all patients, And a large majority of type 2 also has a limited mouth opening. And up to half of the patients with type 3A, this is also the case. And only in the later onset types, the reduced maximal mouth opening does not seem to be a major concern. So the cause of reduced maximal mouth opening in patients with SMA has to do with specific abnormalities in the muscles involved. And that is shown here in some representative MRI pictures. On the right-hand side, you can see two panels of a healthy control. And the C panel, masseter and medial pterygoid muscle are depicted, blue and green arrows. On the right-hand side, the B panel, it's a lateral pterygoid muscle. And this is what these bulbar muscles normally look like. But in a patient with SMA type 2, as depicted on the left-hand side, you will see that the masseter and the medial pterygoid muscle appear quite normal, although they are slightly whiter than in the healthy control. But the lateral pterygoid muscle depicted in panel B is severely abnormal. It's whitened, which represents the fatty degeneration of this specific muscle. And this is relevant because the lateral pterygoid muscle mediates the so-called condylus sliding, which allows opening of the mouth beyond the first 20 millimeters or so. So this really explains why people with SMA often cannot open their mouth beyond these 20 millimeters. And that is something that is relevant in daily clinical practice, because when we looked at the notes of patients who had to go into surgery for scoliosis surgery, we noticed that those patients with reduced mouth opening lower than 20 millimeters often had complicated intubation procedures. And when the mouth opening was still slightly bigger than that, this did not happen. But also in daily life, of course, the reduced maximal mouth opening is an issue, especially when it comes to mastication. And this is what we studied in 27 patients with type 2 or 3 SMA, most of them non-ambulant. And the technique we used was the so-called Thomas, which is a technique to look at mastication. And we ask patients to finish a cracker, to eat a cracker. And during the Thomas, you can look at different issues. For example, the number of bites that the patient would need to finish the cracker, the number of mastication cycles they use, the number of swallowing actions, and of course, the total time that is needed to finish the cracker. And these sides of the Thomas are expressed here as Z-scores on the y-axis, and in blue, ambulant patients, and green, non-ambulant patients. And you will appreciate that although most patients do not need a significantly increased number of bites to finish the cracker, they need more mastication cycles and swallowing actions, and also the total time is often increased. And there is an association with mouth opening, which is depicted on the x-axis here. You can see that when the mouth opening is smaller, also the time needed to finish the crackers, total time on the Thomas score, is increased. But this is not the only issue that patients with SMA encounter. So it's not only the opening of their mouth that reduces or impedes their mastication efficiency. When they chew, they also have reduced endurance. And after 6 minutes of chewing, the so-called 6-minute mastication test, they often complain of more fatigue and pain than usual. So what we saw with the MRI pictures is that the lateral pterygoid muscle was abnormal. And we already saw that also the masseter and medial pterygoid muscle might be slightly whiter. But this is even better to see when you use ultrasound to visualize abnormalities in muscle tissue, bulbar muscle tissue. And as is shown here, large majority of patients with SMA has abnormalities, ultrasound abnormalities in the muscle structure of masseter, tongue, and temporal muscles. And of course, these muscles are important during chewing. So this might underlie the reduced endurance that we see in patients while chewing. So the challenges that people with SMA face during chewing is that their chewing is inefficient, that they can only make small mastication movements, and that they experience reduced endurance. And what we, of course, what does not come as a surprise is that the quality of the muscle tissue, vulvar muscles, is altered and reduced as well. So what about swallowing? Because these abnormalities, of course, do not end in the oral cavity. And as I already said, I will not spend too much time on, for example, swallowing issues. Those have been covered by others, but just a few images to make the point that we should remain open-minded, because in our experience in 21 patients who did a video fluoroscopic study, we did not only find the vallecular residues in a large majority of patients, but also some very unexpected findings in 8 of them, because these patients swallowed, but after swallowing, the bolus was transported back into the mouth, after which patients did another try, and that is what we call bolus regurgitation. And this happened, in other words, in almost 40% of patients. What this actually means, that is something that remains unanswered. But some very striking things are happening during the swallowing process as well. So to summarize, what I try to share with you today is that, of course, we all know that there are feeding abnormalities in patients with SMA. They are quite common, and at least a part of it has to do with the reduced maximal mouth opening. That is something that needs our attention. We have to find a way maybe to reduce this kind of disability. And this is something that affects patients with SMA type 2 and 3, in addition to, of course, patients with SMA type 1. And this brings me to the end of my contribution. Thank you very much for your attention.
I will hand over now to Yasmin. So please, Yasmin, who is with us in the studio, carry on with your presentation, please.
Thank you. So in this talk, I will present the data from our recent UPESMA survey. As Nicole already said at the very beginning of this workshop, at SMA Europe, we think it's very important that we collect data to get a really good view on what the patient community experiences and what the patient's needs are. So our recent survey was on the topic of nutrition. In this survey, we had 1,808 participants from 57 different countries. And as you can see here in the graphs, we had a quite good distribution of patients completing the questionnaire for themselves and parents completing it for their children. And also the distribution with regard to mobility status and SMA type, I think, is quite representative. So in the survey, we wanted to get a better idea of several different topics related to nutrition. The participants from our survey, maybe some of them are watching, they know that the questionnaire was really long, so I will not present all of the results here, but just some findings to give you an idea of the experience of our community. So the first topic that we asked questions about was the topic of eating and drinking abilities. Here we can see that the more motor function is needed for participants to perform a certain action, the smaller the percentage is of participants who can actually do it themselves. So for instance, cutting food into bite-sized pieces was quite difficult for most participants, and preparing and cutting and cooking your own meals was almost impossible for all of our participants. Whereas drinking from a glass by yourself using a straw, almost all participants, or 75 at least, were able to do this. We also asked about swallowing abilities. And here again, we see the same. So the more strength there is needed for participants to perform, the smaller the percentage of participants is who can actually do this. So we saw that, for instance, 84% of the participants could currently swallow their own saliva, but this also means that 16% could not. Whereas swallowing very firm, solid foods such as steak was only possible for about 63% of our participants. So we see from these findings and the previous that there is actually quite a lot of variability in the abilities of SMA patients. We next asked questions about choking. As we have already discussed many times during this workshop, choking is very closely related to swallowing abilities. I'm using the word choking because this is what we call it in our real lives. And we asked participants about their experience related to salivation or secretions in their mouths. And 25% reported having lots of secretions that were difficult to manage. Furthermore, 30% of our participants reported that they were at high risk of choking on food or on their saliva. And of these 30%, almost 60% reported having experienced a life-threatening event related to choking in the past. As we have already said, also I think Valeria, you pointed this out, people really have died because of this, so I think this is a very important number that we should not forget when we are studying this topic. We also asked questions about how this choking impacts people's independence. And here in the bar chart on the left, you can see that for over half of the participants, the possibility of choking really negatively impacts their independence. And also quite a large number of participants does not dare to go somewhere by themselves because of this risk of choking. So I think in somehow we can say that choking really has an impact on people's experience of daily life. We then asked questions about the feeding tube. Of all participants, 12% reported having a feeding tube currently. This number was a bit smaller than I expected, but perhaps I'm a bit biased because my son has SMA type 1. But this is the number that we found in our survey. The reasons for having a feeding tube were quite different. So most participants reported having a feeding tube because of their swallow, but then people also said that it was because of problems with digestion, fatigue, and also other problems such as weight issues. And then among the people who had a feeding tube, 31% reported that they were partially eating by a feeding tube, but also partially by mouth. Okay, next we asked about gastrointestinal and nutrition-related problems. And here, the most frequently occurring problem was constipation. In total, 65% of all participants reported having problems, and constipation was reported by almost 42%. But as you can see, many of these other symptoms were also reported quite frequently, such as difficulties chewing, swallowing, gas, low appetite, weight, reflux, and so on. We then asked some questions about weight and diet. So here, first we asked participants how their doctors evaluated their weight. And we saw that about half of the participants said that their doctor thinks their weight is healthy. But the other half, as you can see, reported being either underweight or overweight according to their doctor. We also asked participants whether they were following a special diet, and here the blended diet was the most frequently reported diet, but you can see also that different diets were used. We were then also interested in the roles of dietitians and nutritionists, and so we asked participants whether they are currently receiving help from a nutritionist or whether they have received help in the past. And what we saw was that 62% of the participants reported never having seen a nutritionist or dietitian before. Then the ones who did see a dietitian, we asked them how knowledgeable they thought their dietitian was. And here you can see that in general, participants were happy with their dietitian, but there was also some room for improvement. And I think the conclusion here is that dietitians really do need to play a larger role in the lives of SMA patients. So there is a gap here that we need to fill. Then, of course, we were also interested in participants' general attitudes towards food and eating. And on the graph on top, you can see that how on average participants actually had quite a positive attitude towards eating. And that for the majority of the participants, their feeding situation did not really negatively impact their well-being and also not their family life. However, there was a smaller group of participants for whom their current feeding situation did have a negative impact. So I think here the message is for clinicians to keep an eye on this and to watch out for how the nutrition-related problems impact their patients' lives. Then we were also interested in the psychological aspect, so whether the feeding situation impacts people's self-esteem. And we found that in general this is not the case, although again here for a smaller group of participants their current feeding situation did negatively impact their self-esteem. And also a small group of participants reported that feeding in public was uncomfortable for them. Then finally, and I think this is actually a very, very important finding, we asked about the current reimbursement situation for participants. As you have seen, our participants came from 57 different countries or territories, so their insurance or national healthcare systems are very different. And what we found here is that 60% does not receive any reimbursement and 13% receives partial reimbursement. So this means that for only 16%, all of their nutrition-related needs, so the services and the materials, are fully reimbursed. And I think this is a very shocking number for me because it also means that the vast majority of our patient population do not have access to the care that they need to optimize their feeding situation. Okay, I will end with a very brief summary of some numbers. So what we saw in our UPESMA survey with 1,800 participants was that there are a lot of differences regarding eating and swallowing abilities. And out of these 1,808 participants, we saw that 30% has a high risk of choking, 65% experiences nutrition-related problems, 50% is either underweight or overweight, 20% follows a special diet, 62% does not have a dietitian, and only 16% receives full reimbursement. I will end here. Thank you very much, and I will hand over to Giovanni.
Thank you very much, Yasmin. I think that this has been a brilliant conclusion of this very inspiring session. With a lot of topics to bring on, honestly. And I think that it's very important to start from the feedback that we receive from patients, families, and so on. And honestly, I was very, very surprised about this very high rate of people not having, for example, a dietitian as part of their standard of care. And this brings us back to the fact that we have these guidelines, recommendations that will be probably new ones published soon, for the implementation also of the treatments, so how the natural history is changing, what we have to implement. But probably it's very important to ensure that at least a very minimum core set of, a standard of care or assessment can be put in place at the individual centers where the patients are monitored. We have a few questions. We have at least even more than 10 minutes to go through these questions. And I would like to start, Tina and Catherine, probably we can start from you. One question is related, and then Ludo possibly, if he can join again. I think that this is a very important question about the adult population. So if there is we have heard about some scales that have been developed for patients, for children, for pediatric children. What about adults? We have heard that a number of scales or assessment have been put together, looking at different aspects. Is there a scale or a very simple, functional assessment like the ORSART or the PFOIS for the adult population, or there is any ongoing effort for the adult service, a sort of screening tool that can be used in clinic very easily?
Sure. So there are a number of oral intake functional patient-reported outcomes that could be used. I know specifically I can speak to what we have done is use the FOIS, the Great Ormond Street version, because that does allow for evaluation across the age continuum, which I think is always the really hard thing to get, is a scale that is relevant for an infant as well as an adult. So based on what we've seen, that scale does a really good job at capturing that in a clear-cut way. And then from that standpoint, from other screeners, I think I had mentioned earlier, but one screener that is a really good tool for older children and adults is the 3-ounce water test, as far as looking at swallowing abilities, which is where you just have an individual drink 3 ounces of water, ideally continuously without stopping. And then if they show any sign of aspiration or they can't complete the task, that would be a failed screen, and that would indicate they should get a more formalized bulbar assessment. And then I do know from a scale development that there is an international group that is working on creating a standardized outcomes across all of these domains that would be across the lifespan. And I think that is being submitted for review for publication in the next couple weeks. So hopefully that'll be out soon.
Anyone else to comment? Ludo, are you with us?
Otherwise, I may jump in. Well, we also focus on patient-reported outcome measurements in bulbary function, and we have some good experience and patient report using the Sydney Swallowing Questionnaire, which consists of some items using a visual analog scale, making also slight differences between several time points more capturable. And we also try to establish the bulbary subscore using the ALS functional rating scale, which also is some kind of patient-reported outcome. And we see also some differences over course of the disease. So this is more coming from the patient-reported side than real hard measurement.
Thank you.
Yeah, I have to agree. The only thing to add on our end is that we also do a patient-reported outcome, the EAT-10. I don't think some of our results show that it was sensitive enough to show changes, but it may be a quick screen that's a one-pager for your patient population.
May I also jump in? Yeah. So I think that there's very different scales that we're all using. We're also using the subdomains of the SMA Health Index burden related to the swallowing issues. And by looking at the subspecific domains, we can also get some information there. We're also using the EAT-10. We're all using very many things. I don't think that going back to the standards of care, I think that there still needs to be some work to be done before we get into them right now, because we need to know what to tell the community and ourselves first as to what is best to be done. So I think that we are a bit ahead with the kids, but not so much with the adults yet. So I think we need to still work on these measures and collect more information so that we can be more precise as to what to consult and what to say, because otherwise there still needs to be a bit of work to be done. So that's why I think that the more inclusive we are at the moment, the more we need reliable and reproducible data to come up with something which is going to be feasible, easy, and practical, because otherwise we won't. That's why the ORSET is very good for the kids, because it's quick, it doesn't require a speech therapist, and it's a first screening. So we need to find the bedside examination with the liquids. It's what's usually done for neurology in the acute setting, so that's probably good. We still need to see if putting it together with the other outcomes, it's going to be the thing to suggest as a first screening. So I think there really needs to be a need for more effort with the whole network and community to come up with some definitive conclusions and then go to the standards of care.
Yeah, I agree. indeed we are seeing, things that we were not expecting, like, maintaining somehow preserved bulbar function, something that was not expected before. So definitely an evidence-based but consensus-based approach. One of the questions that I see here, but actually is quite common that we are talking about, how to prevent some of these complications, is there a way, for example, to prevent the reduced mouth opening? So, for example, one of the questions that parents or therapists often ask is there any specific training or program that we have to follow to prevent, because we see that on the long term, even if we have very good swallowing abilities, but if you have limited, mouth opening or reduced ability of management of the orally manage the food, this may impact, the final outcome. I don't know if you have any specific advice, Tina or Kathleen, about that. So are we recommending patients, especially, before the contractures of the jaw is established, is there any specific recommendation that, probably will be part of the newly developed standard of care, but are we changing the way in which approach this issue?
I can speak to our experience here, but I think that would be a great question for the rest of the panel that does a lot of research in this area too. So initially we had talked about recommending for our historic SMA ones is trying to help to stretch that jaw and can kind of like we would do for other joints as in physical therapy does. Then in talking to some of my colleagues in dentistry and orofacial, they said that you would need to stretch it so frequently and that the babies just generally don't tolerate you stretching that well. It was kind of miserable for everybody involved that they kind of stopped that. Now, I don't know if other centers have other experiences with that. So I think that will be an interesting discussion. I think now as we're moving into like newborn screens, ideally, where we're getting treatment before that, it's not necessarily as big of a problem. What I'm curious what other panel members have done along the same lines of that is once you achieve, if you have a patient that is getting disease modifying therapy, maybe they already have some type of restriction in the jaw, but are you able to maintain that or improve it? Do you have to continue stretching if you get that strength? So I guess I ask more questions than answers. But the perk is that we are seeing that we can get some improvements if we do have a reduction. So I think that's really, really exciting for those patients who haven't really been given much support, I think, to date.
And I think to add on more from the adult side of it, I think this area is really incredibly understudied. And I think you have to understand if it's a mechanical problem as to why the jaw is not opening, or if it's contractures or tightness. And if it is, I mean, the literature out there in general for contracture and tightness, even with stretches, the likelihood of effectively lengthening a muscle to where it could be functional is not likely. And so I think prevention is also very key. One of the things, this is not my area of expertise, but I do have therapists who I know who are temporomandibular joint, therapists, basically, and they work very closely with dentists, in which we do refer some of our patients to see those therapists to address the mouth opening difficulties.
Thank you very much.
Can I maybe add to that? Or
No, you go ahead.
As I mentioned already in the session before, I like to often ask adult SMA patients what they would have done differently or what they would have wanted their parents to do differently. And many have told me that they wished they had spent more time and effort on maintaining a larger jaw opening. I think some of the things that have not been mentioned yet is that this, of course, also prevents intubation if they would need it later in life. And also going to a dentist is very challenging if you cannot open your mouth. I have seen some parents use it's not a brace, but something that can be put in the mouth.
Yes.
Does anyone?
Bite, something. Yeah.
It's like a
But,
Yeah.
Does anyone have experience with that, or what are your thoughts on that?
Well, we don't have the data yet, and plus it's not my field of expertise. I am a neurologist, and this is something that speech therapists usually do. But I think we are at the point like we were with the motor skills. Now that we're looking at the recovery of some of the motor neurons, and we're looking at that it's also part of, yes, it's mechanical, but it's also muscle, and it's also posture. I think there is a variety of ways that we can target this district here, which we have sort of ignored so far. And even with treatment and with physio, and I don't have experience, but I know that we are now working on some of the thinking of having some exercises for the mouth opening, because if it's muscle, if it's motor neuron, yes, it's mechanical, but if we start before it's a fixed contracture, we may actually work on the opening. And as all treatment needs to be continued and persevered, and it can't be done like 3 times a month. It has to be continuous, but I think there is space there for more work to be done again. So
thank you.
We're not ready.
One very quick question before closing this session for Yasmin. So there is a lot of interest about the survey that we have performed. Any plan for publication, and especially to provide a breakdown for ages, SMA type, and so on? Can you give us
Yeah,
some
absolutely.
feedback?
We are preparing the publication, and we are also preparing infographics that we will distribute in different languages.
And this leads us to the conclusion of the session, and thank you for your attention.